in Dadaab, Hagadera, where I worked for a period of 3 to 6 months. From there, I've also been working in other organizations as a volunteer. That includes Out Relief International. I was a lead consultant as the medic because it deals with One Health, which works both in Kenya and Ethiopia. Currently, I'm Vice Chairperson of Kenya Medical Association, an organization that brings together all doctors, and it's divided into chapters. So I'm in charge of, I'm the Vice President of the same organization in Kisii region in Migori. That is basically what I can say about myself, Mr. Chair.
Thank you very much.
Thank you, Dr. Welcome.
Thank you so much.
And congratulations.
Thank you so much.
So you came in with a very big integration, solidarity. We also appreciate you. So Dr. briefly, and I know you understand that our Constitution 2010 gave us evolution.
Yes.
And in that regard, we have two arms of government, that is the Assembly and the Executive. Briefly, in less than 1.5 minutes, without going to further details, can you explain to us the roles of the County Assembly?
Thank you, sir. Like you said, in the wake of the Kenyan Constitution promulgation 2010, we got this, our government was involved. And of course, in that evolution, there is a county assembly, that which does legislation and also does oversight in the aspect of separation of power, so that it can oversight the law that the executive does. And also, they also do representation from the various community. They represent the public in government. So I believe through these aspects, the county assembly has a big role to play in terms of governance.
Thank you. You talked of principle of separation of powers.
Yes.
So in your own judgment, to what extent can the executive work with the assembly and vice versa, and without compromising on their role?
Mainly, it's the county executive does policies. It does plans for the county. Then the county assembly will receive these policies, will receive these plans, and approve them. It cannot be able to run without having been approved by the county assembly. And also, they help in oversighting on the management of the resources that are within the county. So I believe those are some of the areas, among many others, that the county assembly has.
Thank you.
Thank you.
Now, I tell you all,
Fine, sir.
why are you not referring to yourself as Dr.Ombati? Because I'm not added anyway.
I think it's a prefix. It's not really part of my name, but it's a prefix that is there. However, it's now, I've carried it along. So one thing I believe, whatever that I do in my service, which is giving care to the patients and all that, will precede the prefix that comes.
But it's a title you worked hard for, very long to add. Why don't you
I'm
flash
happy
that
about
out?
it. I'm happy about it. I mention it every time I say it. The only challenge I found is that whoever wrote me then the invitation letter to come here from the assembly or from wherever it was written, the name was written as Mr. Ombati. I didn't want to project or protest, but it's a title I'm very happy about. It's a title I'm very proud of having earned it after all this time.
Now, the great people of Nyamira could want to, they approve you to be the CEC head.
Yes.
We really want to know that the person we have at the end is a doctor. So get used to it. Flash it around.
Very well, very well.
Now, you talk about 2010 constitution, talk
Yes.
about separation of powers, you talk about what Nyamira has asked you. The 2010 constitution came with goodies to the Kenyans. One of the benefits is involving some functions. You have my question?
I get it.
What are some of the functions that you are involved to?
It included health services, the department that was given a chance to lead. Agriculture was involved. We also had devolution of transport and public works down to county governments. Animal husbandry, this aspect was also involved. We also have the county plan that was involved, and infrastructure. Roads were also devolved to the counties. There are some implementation of some specific national government functions that were devolved. On resource management and mobilization, environment, some of them also devolved.
Now you talk about health as a function.
Yes.
And in city, you are in charge of our referral hospital.
Perfectly said.
What is the stage, what is the condition, what is the status of the referral hospital now being the head, if you are to describe in a 1 minute? How is it now being a referral hospital? How do you
In 1 minute or less, I would say Nyamira County Referral Hospital is with a projection, with a growth trajectory since I joined. That is the only thing I can say about Nyamira Hospital. If you allow, I can say that by the time I came in, a number of issues that were happening, our patients, especially when we had fracture patients, used to be moved to Tenwek, and this is a facility which is close to our county. But right now, as I'm talking to you, since I joined, because I joined around November last year, we started to make plans, and since March, we started doing orthopedic surgeries in our hospital, and I can proudly say that it's one of the achievements that I've done in that facility. We've done over 200 orthopedic cases as we talk now, which have been very positive. Patients have gone home happy. We've had a challenge with management of patients within our ICU, and I can say that since I joined that facility, and with the support of the staff that we have, we've been able to manage approximately 100 to 150 people. Of course, in the process of management, challenges might not miss, but I can say it's been a real win for our facility. For a long time, our facility, Nyamira Hospital, has not had strategic plan. And strategic plans are the roadmap towards a development of an institution, development of an organization. And I took the bold step, and recently we started doing that plan, and we have a zero draft which is ready for participation. And we need to take it out to our staff, they participate, and see if whatever that we've done lies within that. It's a 5-year strategic plan, but we are going to divide it and break it further into mid-term, short-term, long-term plans, and see how we can grow that facility. As I came in, cash collection in that hospital used to be around 1.2 million to 1.5 million. And as I'm talking to you last month, we had a collection of 3 million in cash. And when you bring in the NHIF money that has been coming in, it will go to around 7 to 10 million.
Now, thank you for that. If this committee approves you, in charge of health department in the county, then you'll be at the helm, probably making proposals to various health facilities. What is it that you need that is not available in your facility now? And when you find yourself in that position as CEC, you recommend to be done to the referral hospital. What is it that you've not gotten, but if you had a chance to be ECC moved to the hospital?
Of course, now
to make it better.
To make it better, this includes on one part facility we have there called the Doctor's Plaza to be completed. Once that plaza is completed, then it will give me room that my consultants can be within, see the patients within. As we're here, some of us can will fall sick and will want to be admitted in a place. Not that we cannot be admitted right now where the facility is, but because of the status in the community that you have, you might want to be in a separate area where you can be able to be managed. So if that facility can be completed, it will be a plus for me. The second thing is we've been referring patients here for MRI. We have got MRI machines across the facilities that are around us. One of them that has an MRI machine. But you look at the kind of MRI machine we have there, the 0.5 Tesla. And we need at least a 3 Tesla, which is only found in one facility in this region. This is MTRH. So we can have that facility here. Even the patients we send to Nakuru for MRI, they go for a 1 Tesla machine. If we can have that machine here, then we can be able to even attract people from across our region to come and get the services from here. Apart from that, this facility needs infrastructural improvement. At the level I'm seated in, of course, we have the FIF that was passed, and it has been assisting us a lot. But the money we get is not enough to do the structural support that we do there. So at that position, at the policy level, at that level where I'll be seated, then I'll be able to, in collaboration with other departments and other players across, so that we are able to improve the infrastructural outlook of that facility. Up and above all, this facility has among the best consultants this country needs. The only thing this consultant needs is support. They need their voice to be heard. They need to sit in decision-making bodies so that together, and this is basically what I'm bringing on board, that we bring everybody, sit with them, make decisions together, and through that, by listening, we can be able to make the changes that we might want to that facility.
Hello, Mr. Ombati.
I'm fine.
You're welcome to this board.
Thank you so much.
You're looking smart today.
Oh, thank you.
You're welcome. You're going to become the county executive
Yes.
in the medical sector. What are your major roles?
As a county executive member, one of my main roles is policy formulation. We sit and look at policies that will run the department. Secondly, I need to do regulations that will be presented to the Assembly for the running of the department where I am. Implement the county legislation. Once the county assembly sits and they present to us the legislation that has been passed, it will be my role and those in my team to make sure that the legislation has been implemented. We have other functions that the national government does or they want to be implemented in the various counties. As a CEC member, it will be my role to make sure that those are implemented among the many others.
Congratulations for the good work you've been doing and the referral.
Thank you so much.
And the voice of the people that said it has improved in Kenya are proud to the drug. The drug supply. What are you going to do to improve?
And for sure, just like you said, Honorable Member, this committee, it has been a nightmare. We have to agree together in this committee that generally we have had a challenge in this aspect of drugs. And I've been thinking about this since I was given this nomination. What can I be able to do at that level to make sure that the drugs are available and at all times? As we were trying to come up with a strategic plan for the hospital, this I know is going to help us in bringing it to the higher level, because now we're looking at the various facilities across. We used to have something we call a revolving drug fund, where drugs used to come in, where some fund was set aside to, that was in the early 90s, even before I entered into my primary school. There used to be 1 year. Then towards the dispensation of the new constitution and the county government, there were challenges in making sure this is implemented. Now, as we were setting up our strategic plan, one of the things we were looking at is setting up a product unit, health product and technologies unit. A unit that is a standalone, it will be funded, because our funding is not really enough. Right now, our county government, the Department of Health receives around 120 million of drugs. But when you look at this amount of money that we are receiving, and the skyrocketing in terms of costs out there, you realize we are short of what we are supposed to have gotten. Basically, we need approximately 200 to 250 million to make sure that our drugs are in constant supply in our county. Number two, another big challenge that we've been having is the process of procurement. That before even the procurement process is over, so that we get the drugs that we need, because various companies and various organizations have different ways. You realize that the drugs are over and you have to wait for an extra 2 or 3 months before you get other supplies. And number three, we also have the challenges that struck KEMSA. KEMSA has been supplying us. It's a government agency that does supplies to us. And I want to say that our county CEO took a very big step through the support from the Assembly, and we were now allowed to get drugs from other organizations and companies away from KEMSA. The challenge that comes with this is some of these organizations we have to pay in advance before you get the drugs. And like KEMSA, where you can get the drugs, then you process the payment. So if we set aside a fund, and this fund has a continuous supply, which has been approved, it's one of the things I will sit down and work closely with the Assembly. We make sure that that fund is operationalized, so that this money is set there, and once this drug is over, you can now be able to call for another drug to replace what is over. This can help us to have a constant supply of the drug. We might not be able to do it across the county. If we can start with a pilot facility, let's start with our main facility, because the number of people who visit our facility here per day, we have approximately 200 people visiting our facility per day, approximately. So you look at the whole month, you realize the number of people coming to our facility. So if we can start with it as a pilot program, a pilot facility, we see how it runs, then we can take it down to other facilities. Through this, I think I will need serious support, Mr. Chairman, from the Assembly, so that we can see how we can end this challenge of drugs. However, for the last few days, what I used to do in my facility is apart from the drugs that come through the procurement process, FIF bill, which was passed, and I want to thank so much the chairman who seated here and the rest of the members who are with us, who played a big role in making sure this fund is passed so that we can have money in the facilities. The only thing we are waiting for is the regulations that will make it functional properly, and this now will help us to buffer, just in case we have a challenge of drugs, before we get the larger supply which comes from cancer or meds or any other company, we can buffer as we wait for these other drugs to get to our facilities.
Okay.
Yes.
Before we get continue further, I noticed something in your CV. In your presentation, currently you are the lead for support.
Yes.
Maybe I could be having around CV because it's not important as your current work experience, as your current workstation.
If you allow Mr. Chair, I think I'll check and make sure that it is with you before this is done.
Thank you, Dr. How are you?
I'm fine.
It's like when you introduced yourself, you did not study the word Daktari. So that's why some of us are calling you Mr. And maybe that's why you were dressed as Mr. So it starts from you.
Oh, yes.
Now, in the 2010 Constitution, when Kenyans were clamoring for the change of the Constitution, you were a student at Kampala International University.
Yes, I was.
Now, what was your feel then? How did you feel this thing when you were a student?
It was a big unknown. I couldn't really understand. I couldn't put, end to it of what really was going to happen, especially involving healthcare. Let me be specific to healthcare. As doctors and healthcare workers in general, we were used from being managed at a central point, and how we were going to be managed by 47 counties became quite 48 governments, including the national government. It became quite a challenge then. Later on, as I came in, there are a few things that I noted. For the first time, I remember I visited this hospital before I was given a letter of degree. I saw a fleet of ambulances, something that had not been seen here for quite a number of years. We realized, quite a number of mushrooming facilities in areas where people thought that we cannot have facilities, healthcare facilities. But now still a challenge came on management of the healthcare workers. And that is why you realized that for that period of time, there was perennial strikes from various groups of healthcare workers. Today there will be doctors, the following day there will be this group, and all that. Because even them, they are not really contextualized what this was. But as I sit here today, I can say it is one of the best things that happened for this country.
Now you are happy with the evolution?
Oh, yes, yes.
In relation to where you work, and you intend to become the boss in the department, is there anything you can do to deform the functions further to the dispensary level?
You've rightly said it, Commissioner, but we have levels of healthcare. We have hospitals, that is level 3s and level 4s. We have health centers, we have dispensaries. Whenever we are having this, and of course now as I was looking through how healthcare has been broken down, we have got a level that will be looking at primary healthcare. and we have one that will be looking at the medical services. And you see, right now, let me give a simple example. When COVID came, we were wondering when we're putting on masks. But later on, we realized that for a long time, we didn't have flu. Why? Because the public health aspect had been looked at. So if we look at such kind of small things, primary health care, that it solves at the ground, it will help us not to be getting a lot of patients coming to the hospital for simple ailments that can be managed through advice, through home visits by the community health volunteers who are now part of the system, and such kind of thing. So what I can say is there is a great improvement, and what I can do while sitting there is to make sure that we empower the primary health care. And by empowering the primary health care, it helps us to avoid some of the issues on the ground that bring people to the hospitals every now and again, and that will leave the main facilities to be looking at serious diseases which can make our people to go into research. So I think those are some of the areas we need to carefully look at.
On that note,
Yes.
you talked on primary health care, and I know you are aware of the fact that we headed two departments,
Yes.
primary and
Yes.
medical services.
Yes.
So in your own judgment, among the two departments, which do you think should have a bigger allocation of the budget? Why?
In the allocation of the budget, Mr. Chair, healthcare, however much, like I've said a few minutes ago, that primary healthcare is very key. Because once we manage the primary healthcare, once we manage some of those emerging cases from the communities, we can be able to avoid admissions and such kind of things. One thing we must appreciate is that we need enough resource across the two areas, enough resources. I cannot say that we have to put a lot of money in this and this, because if you come to the main facility where medical services will be looking at critically, we need technology, which needs a lot of money. However much we also need money on the ground, which will help in the management of payment. So I can't say that this really needs a lot of money, this needs a lot of money. It needs us to sit together as a team and know how to allocate this money across Mr.
As a layman,
Yes, sir.
in my own opinion, primary health care actually is a preventive measure,
Yes.
and medical services is curative. So if I say, given a chance, or in my own opinion, I will get more on primary so that we do more prevention than we sort curative. Will I be wrong?
You'll be right. From where you sit, you'll be right, very right. But also from this other side, as a professional, one other area I also look at is whenever we are having the patients coming to the hospitals, we need subspecialization. We will need some of the specialties which need technology that need quite huge amount of money. So I'm actually putting money in the preventive health care or primary health care, which is very important in the running of our health systems. It's also very important to look at how, and you see, technology changes every day. Today we might buy this machine, the following day machines are changing. Today we might need this kind of sets to run some surgical procedures. Today we'll need some machines to run some of the cardiology and all that. But we realize that these things need also a lot of money. So the allocation will be based on of course, I have a much we need a lot of support on the ground, but also need our patients who have visited our hospitals to be looked at very carefully. So I'll be very careful to say how much, which one will take a lot of money, which one will not take a lot of money. I will only say that we'll sit as a department and look at the needs at that point and what we need based on the strategic plan for the department.
Dr. Ombati,
Yes.
in 1 minute, can you tell this honorable panel what Nyamira County will miss if we don't approve you as a CC?
Oh my. The knowledge, the expertise, the level of mobilization that I am blessed with, I mean, how I work closely with my people. Like I said, you've not had strikes for the last few years in Nyamira because of the, how we've been handling the stuff around us. Such kind of expertise you will not want to miss it. Thank you.
Now, taking up from what my friend has said, my colleague has said, the staff that work for you, where we say, we have this cadre called community health volunteers, a very key segment in the administration of, the health administration. Now, but they are forgotten a lot. I'm meant to understand that there is a proposal that they be given around 3,000 per month for their sustenance. From where you are, and from your aspiration to be the chief officer in the Ministry of, this Department of Health, CC. Do you think the 3,000 proposed for the community health volunteers is sufficient? As much as they are volunteers, yes, but do you think it's sufficient to see them through and work effectively? And if not, what do you think is sufficient for them, given the state of the, kind of our county in terms of revenue?
Just like to say, these people are doing a lot of work for our health department. Secondly, there is no money which will be enough for them, but all we could give them, because of the kind of work they do. They are the ones who walk to the villages. They will make sure these people have toilets. They will know who is sick in whichever house. They will know how to bring them to the hospital. The kind of work these people do, I have to appreciate that the money that has been proposed is really not enough. However, for the last several years, committee, these members have not been getting anything. They've been doing all this work for free. And by starting at this point, I think it will be motivation enough for them at this point, so that as we move on, and as we look through our budget is never enough all the time. We can find a way of also adding something as we move forward. Another thing we've done for them, that will be done for them according to what was looking through the legislation that was passed, is apart from the 3,000 that we are giving them, we are now paying for them the NHIF part, which really plays a big role.
Which is a reduction from the 3,000, I believe.
Well, I need to look through very carefully, but from what I was informed, it's not part of the reduction from whatever they are getting. It is. So it is. Then, like I said, when looking back at what they were earning, they were getting nothing at that point, and right now they are getting 3,000. Of course, which is not enough. I have to agree to that. It's not enough. As we move forward in the implementation of the plan that has been set, we will see how to improve their welfare, improve their remuneration, and see how we can.
Dr. Ombati,
I'm fine.
you will not see to any water.
Oh, thank you.
That is gracious.
Thank you much.
Sit till that God. You have a lot of service to account. You deserve this to be service you today. And what's the difference between KMA and KMPDU?
Kenya Medical Association looks at the welfare of doctors and the workers, but it is more into professional growth of the doctors. And it is only a faction that looks at medical officers, both consultants and all that, and dental. The unit called dental. However, this unit was still to be, the dental aspect was taken out of KMA, and they held their own association called Kenya Dental Association. KMPDU is the political unit of the doctors. But now this brings together all doctors across, from medical officers to pharmacists to dentists, all them go together. Yes.
In our referral hospital,
Yes.
how many departments or sections do we have?
We have around 23 sections.
23 sections.
Yes.
What is the total budget for health? Current total budget for both the current and enrollment?
Around 1.8 billion. Around 1.8 billion.
Okay. In your own opinion, what value can automation of our systems and the interlinking of the various facilities that we have across the county bring on board to our total healthcare system in our county? What value can suppose we go that way?
We go that direction. We are bringing the monitoring and the evaluation of our systems close. And secondly, we can be able to now, because the interlinking I think you're looking at is not only in products, it's also looking at the health workforce. It's also looking at the financing aspect. That is basically, so wherever you're seated and you're looking at what is happening across, you can be able to see whether the services we are rendering are getting better or there is a downgrade. So it will also help in planning, so that you know how much you give, how many, workforce, how much workforce you need on the ground. So another thing is we are slowly moving out of the paper aspect. We are coming into information technology, of course. So I think that is basically what you're trying to look at. So the most important thing that we're going to look at is how we monitor and evaluate our services.
Okay. Now, this FIF, what percentage in the process of drafting the regulations and the policies that we like its usage, what percentage, in your opinion, should go for development? And in this aspect, you talked of where you really needed the doctor class and you need that. Do you think a certain percentage of kitty can be apportioned for development?
Exactly. Like I said, the amount of money that we receive.
Excuse me, there are those particular private gadgets. This you are not allowed to take videos of the content in here, except the media houses. So you can excuse us, please, for now, and you turn them off, put them in your pockets. Thank you. I think I'm clear. Sergeant.
Umesema simu. Umeenda wapi? Umeenda wapi?
Trying to move this side. We don't want you to encroach to the speaker. Move this side, please. Don't be behind the speaker. Why?
Okay, thank you. You can proceed, Dr.
Thank you so much.
Yeah.
Like I said at the beginning, we receive approximately 1.4 billion. Part of this money is FIF. It's part of the money that we receive. It's also calculated.
Yeah.
FIF in itself is not sufficient enough to do any other major developments, like finishing the plaza which I've spoken about, and doing major development and infrastructural development in the facilities. we will need some little other support from either the appropriation bill money that we get from the national government. This is where we also bring partners who will come and support. So basically, we need quite a chunk of it in the development aspect of health facilities.
How much do you owe KEMSA?
As of now, it's around 30 million. Not so sure of the figure, so I don't want to be quoted to say the exact figure, but it's around that figure, around 30 million.
Okay. How long has it taken? How long has been the debt?
The debt has been here for almost 3 years.
3 years. What is your opinion on the healthcare commission that has proposed probably by one of your colleagues? Health commission.
The Health Service Commission, according to me, as a body that brings together all healthcare workers under one umbrella, will be very beneficial to our staff, because now there will be a central board. This will help us in other ways, including having, like now, if Nyamira Hospital doesn't have enough staff, and there is a county that is overstaffed, or there is a county that has a little bit more staff than Nyamira, through that body, we can have the deployments centrally. And of course, we don't have to go to 48 governments in seeking for the welfare of doctors, or healthcare workers, nurses, clinical officers, and all this. We don't have to go to the various bodies that govern these institutions. It can be done centrally. So I believe it will be very beneficial.
Now, you was in charge of our 5 years, by implication, in charge of the whole. What systems can we put in place, or what systems are there in place to detect negligence by our professionals in the various facilities? Negligence.
Continuous supervision. Continuous supervision is very key. And regular and, supervision that is objective. Areas that we need improvement. So supervision around that area. And there are times you realize that our people have not gone through, since they left college, they are now working with us. There are changes in management of patients. So trainings are also very key. So as you do targeted and objective supervision, you look for areas where you can improve. And these areas which will need training. There are those trainings that are long-term, others are short-term. Others we call the fresher courses. Very important. Up above all, we need, like I said, we need to find a way of linking our facilities. You can pick one as a pilot to facilities either within the country or out of this country which are performing better, so that they can learn from each other, they can share knowledge, and from that it can also help in reducing negligence, like you said.
Okay, last but not least, what is your current salary?
I earn around 212,000.
What is there for your network?
My net worth, all my assets, and because I don't basically have my personal assets, we do it as a family.
Yeah.
It's around 10 million. Approximately 10 million.
Thank you, Dr.
In part of the application process, you are supposed to submit a questionnaire. It's missing. So you can organize for the same. I don't know if you are supposed to submit a questionnaire.
I presented it, Mr. Chair, so maybe I'll follow it and know have represented it. However, if it is needed further, if it cannot be situated, I can still present it right now.
Now that we have alluded to the fact that there is a thin line between primary health care and medical services, and I know you realize the fact that we are managing two departments with a chief officer, so two chief officers, two departments. And I know as a manager, you anticipate conflict or power in that kind of arrangement. So what is this one thing that we do, all the measures we put in place to ensure that the ranks of conflict don't actually trickle down to affecting the service in the hospital?
I think continuous engagement, that includes meeting, being transparent, and sharing what is there, and up and above all, alternative resolution is very important. Finding alternatives with all these challenges that are coming. Those disputes will always be there, but getting alternative dispute resolution is very key. Instead of putting yourself out in the public on what is happening. So engagement is very key. Engagement, continuous consultation, and sharing, and meetings, and consultations up and above you. There are people, I might not be the best, there are people out there who are better than I am. So if we can involve the players in such kind of patterns to come in and help us engage, including the county assembly, they will help us in getting to resolve this.
Dr. Ombati, tell us at least two of your weaknesses and two strengths.
Maybe I can start with strengths. I can say that I am a very patient human being, very patient. And
Are you more patient than a patient?
you say that
Yes.
yes,
Just go on.
I'm very patient. I consult a lot. I can't do it alone. I consult a lot. And I think one of the weaknesses is trust. I trust too much. It's one thing. It's one area I'm working on. Sometimes you might trust too much and you even lose yourself. And another area of weakness is I engage. I never want to. Nowadays, I've started to reduce it. My engaging with people around me, engaging a lot, social media and all that. So I'm trying to avoid it. It's a weakness I have, and I'm trying to avoid it a lot so that now I'm getting into a very high.
You are a socialist.
I'm trying. Yes,
That's a strength. Now, on that, can you give an example of one of your life issues that you have addressed by patience? What is it that you are too patient until you became
I think it's very emotional for me. But I was a unionist before I became, and now became a leader in the association. And I said it's emotional.
No,
Very emotional.
yeah.
Yeah, but now, in the process of being a unionist, I think, one way or the other, you step on people's toes. And I stepped on toes of people who were preceding me. And that is when I realized that I was becoming a threat in dispensation. And in that process, I was taken taken out of our main facility, taken to a level 4, level 3. After that, I was taken to a health center where I was being managed and making sure that I clock in and I clock out. And my salary was stopped for 1 year.
Your salary was stopped for 1 year.
But all this time, I was patient. Some quarters were telling me to resign and find alternative environments to work in. But I told them I was born in Nyamira and I came to support my people. Not earning for 1 year is not a joke.
Yeah.
Yeah, but out of my patience today, I'm being vetted as the CDC now.
Yes.
So it's been a journey, so that is patience, man. That's why I say it's emotional. Men don't cry. But, it's very important.
Thank you. We take a minute of time. You said well that you have doubled the revenue collection on the facility.
Yes.
What's this new thing you came about with that has resulted in that high revenue collection?
Apart from FIA.
Apart from FIA, yes. Because this, whatever money I collect is the money that goes into FIA. So as I came in, I identified areas that needed improvement. One of the areas that needed improvement was one of the functions I mentioned there. That is the function of orthopedic surgeries. So I delved into it. As you do this, there's something you do, there's something you look at, that if you make this bottle fall down, the rest of these bottles will fall down. So that is the area targeted and raising the revenue. The second thing is we realized there used to be pilferages, loopholes where financiers could not get the targets. They could not get to the collection point. And to put a bit of stringent measures, making sure that all monies that are received are not used before it has been banked. And secondly, patients coming to the hospital receive the services they've paid for. And thirdly, making sure that some of these supplies, that is where you go to a facility here and of course the facilities, making sure that some of these commodities that help services to run are there despite the fact that you don't have enough money. So you will get into debts which are accepted. You don't go beyond the limits of the law. You get into those debts and make sure that whatever that you need to make the hospital run is there. And above all, like I said, I have a challenge of Nyamira said, a socialist. I had to now engage with the public through the media and tell them, no, this is happening. And people now started coming for those services. There is trust which had gone low when I was joining the facility. And I can say, however much we've not hit the target of that trust. And now, as the CEC, you've approved, I will work very closely with whoever will come after me so that we now gain the trust that is needed. And above all is now motivation of staff. We say we might have everything, might have all that we need, but if our staff are not motivated, they will not render the services that you need. Motivation doesn't need money. It needs you to appreciate them by word of mouth as you pass around. It needs you to be there also, be available. When they need you, be part of it. And actually, I want to say it before this panel, that even when I'm going to become the CEC Health here, I'll have an office in the hospital where once, when I'm not busy, I'll get to theater and do surgeries. I'll get to theater, let these people see me there. So while there, they will be able now to share their challenges with you. As they share, the motivation will, So those are some of the things I looked at to see that some of this, and also now the financial, the collections, we had to now put into action the NHIF aspect. That we now closely follow the NHIF, make sure that it has been approved, the pre-ops have been done before the patients are going for surgeries, before patients are seen. But in that process, of course, we'll continue seeing the patient. So I think those are some of the measures I've put in place and many others.
Well noted, well noted. Other than the infrastructural challenge, those systemic loopholes. I mean, you have served in Nyamira for 10 years.
Yes.
I mean, what are those systemic loopholes you have realized that are so glaring, and what is the alternative?
These include laissez-faire kind of leadership. Laissez-faire. That this one is a doctor, he knows what he is going to do. So we don't have somebody supervising and monitoring. And that is why I said in my earlier submission that moving forward, one of the things I'm going to put ahead of my service delivery is continuous supervision. Because when they know you're coming to supervise them, they'll be on duty. I don't want to mention a facility here, but allow me to say something. That I went to some facility in our county recently. As I visited there around 3 p.m. I mean, the staff had moved out.
Basically closed.
Yes, the facility was basically closed. The moment I stepped in that facility, the governor had mentioned my name as the CC. They thought I've come to know what is happening there. They came back running to the hospital. So that means there's a weak point at that level of close supervision.
So how are you intending to do this supervision? Will you be periodically moving to the facilities?
Oh yes.
Or there are mechanisms you can put in place?
Oh yes. Personally, I've been moving periodically to those facilities, but at the county level, departmental level, we have a team that does supervision. So my role will be to facilitate them enough so that they can be able to move around and supervise whatever that is happening. And the supervision we are doing here, I want to say it, members of this committee, we are not doing supervision of wanting to say, huyo hajakuja kazi leo and we are going to take him home. No, we are doing targeted and objective supervision. And we keep enhancing our services. But of course, there are areas you might find people have gone overboard. HR disciplinary measures are taken into
Thank you. You are so useful, and you know we're in a technological. Is there something better we can improvise?
Oh yes.
I mean, what is that?
Yes.
You have any plan regarding that?
The IT aspect. I think by now there's a program that was supposed to be rolled to the facility, to the county, and to the various facilities that we have. And that is why in my also submission, as I was saying, if we can have an IT team at the county level, apart from the physical supervision, that is very important also, the IT aspect will also help us. Because there's that aspect of clocking in and clocking out. So whatever there is whatever that is happening in Chepngombe, for instance, which is within Nyamira County and at the far end of Borabu, we can be able to see it from the office, and that aspect it will help us a lot. Monitoring whatever is happening, both in commodities, in human resource, and all these other aspects, even of service delivery.
Thank you, and that's what I wanted to hear, because this thing can be done on a daily basis,
Oh, yes.
and we can be somewhere. If that one is part of your policy,
Oh yes.
I mean, do you have another 2 things that you think you'll front that can help the department run and do excellent for the country? Do you have another thought, like in terms of a policy that you want to present, probably in your first days in office?
Whatever I've said, it's a policy that needs to be looked at. That is the IT aspect. Policy. We also have close monitoring of our commodities. Like I said, we want to do an HPTU. That is the Hospital Products and Technology Unit. Of course, it's something we need to present, and it is passed. We are so that it is guarded by law, so that our drugs, our products, our technologies are continuously monitored, and that can help us a lot. I think those, among others, will sit with the department and see what is key we can be able to.
Thank you for that. And you are serving in one of the best, there is a referral facility in our county. Are you impressed by the way, how we handle our emergency care cases, especially about fire authority? And in case, if so, do you have any plan or mechanism, or what is the solution for that?
Mr. Chairman, I've also to say that we are trying our level best, but we are not doing our best. And that is why the moment I got in to that facility, one of the things I did is to set up an accident and emergency unit. It's not yet completed. I think there are a few things hitches here and there that held us a bit, but one of the targets I had is that before November this year, which I'm trying to see if it's possible, before 1st of November, our casualty will have started, however, not to the best of what we want. So with that, once given the opportunity to sit in this position, there are areas, like I said earlier on, that we have people, we have facilities, we have organizations that have done better. So in our emergencies, there are two areas we are looking at. We are looking at the ambulatory services. We look at our ambulances, the drivers we have, the stocking of ambulances is not the best. So with that, we already engaged as a facility itself. We had already engaged with Kenya Emergency Care and Red Cross. We had already engaged, and we've done already a letter to them. They were supposed to come and do training to our staff and do training, help us in knowing how we stock our ambulatory unit. And of course, having an intercom so that you don't have to call the hospital. Whenever there's an emergency, you call the ambulance driver, who is a paramedic, and you continue with that. They come for the support. So that is one aspect. The second aspect is now at the facility level. Our staff training is very important, because those few minutes will save a life. If they are not trained, we lose a life that would have been saved. Number two, stocking of our emergency unit, and making sure it has, if not everything, but most of the commodities that are important in the care of our service. So there are people, like I said, there are people out there who've done better. Partnering is key. So that even if we do this skeleton of what we think might be our emergency unit, we have people of goodwill out there who needs our hands to be open so that they can come in and support in making sure such units are up and about. But above all, the facility we have here now might not be enough. So if we can look at a long-term project of setting up an emergency unit with a complete theater, with a complete admission unit, with a complete, all these other aspects that are needed in emergency, that will be a dream come true for me, this period of 5 years.
Thank you. And you have said about that. How many drills, like the CPR drills, has the facility ever done to its staff?
We haven't yet.
So let's say we have had clinicians, nurses who have worked there for 15, 20 years. Yes. Then how do we expect to have an emergency? If we have medics who never go to drills, who are not updated on the current happenings on how to respond to emergency cases, like a simple CPR. We have cardio diseases. The things where a normal human being who looks healthy, who looks okay, who presents himself to the facility, and then the health situation goes worse within a minute. Do you agree with me that people have lost lives right at the facility or in line just because we don't know how best we can be able to assess an emergency situation from just taking vital signs?
On that, just before,
yes,
I'm putting more input on that. And I have a very recent case. A lady with the husband, who brought in a son on a Friday. After all the medical checks were taken, according to the medic, he had the boy was very much okay. And the parents are insisting this boy is sick. Okay. So the medic's verdict was take the boy home, the boy is dead. Okay. Now, come Saturday, the parents were not convinced. Saturday night, they did not have the boy okay. As much as you told her this boy is okay, we as the parents feel that the boy is getting worse. It's getting worse. You subjected the boy to the various tests that you do in that facility. According to you, the boy was okay. And the parents were told take the boy home. And that was Saturday night, 11, 12. Now, the parents were even pleading that you cannot give even an aspirin, you cannot prescribe even an aspirin. No, the boy is very much okay. So the young boy was taken back home. Okay. On the race of Sunday, by 8 o'clock, the boy was passed. That's based on that. The ability of our elites to detect, because now, after that, the underlying, the layman's view at the village now was that actually this boy had what we call pneumonia. Because as he was dying, he did what? He passed it with a lot of blood from his mouth. Now, don't you think there was a negligence, either because of lack of knowledge, or, I don't want to say it's intentional, lack of knowledge, and in that case, lack of training, to detect beyond tests, lab tests and all that, that ability? Is it because our people, our elites have not been subject to training?
Thank you for that. And now to say that I said this in advance in my earlier submissions. I said one of the areas that we are going to look at very carefully is trainings. I say training, some of them are short-term trainings and long-term trainings. Number two, there might be knowledge, but maybe we might not be having the best facilities in terms of machines to detect some of this. Pneumonia is that can be detected in a facility by even by a stethoscope. Pneumonia. So I can't say it was really because of that poor of that, but maybe there might have been something else. Because whatever they are saying in the village, the layman's understanding it's pneumonia because the patient has vomited blood. But there must be something else. So answering what the chairman has raised, I have to say that equipping the emergency section and training of staff will be number one consideration. So that the staff we have, Chair, CPR can be done in a facility. We have CPR machines in the hospital. We can do them. But the number of staff who can be able to do them have been, because of the number that we have, we've placed them in specific areas where they are really, really needed, including ICU. In renal units sometimes where conditions can change anytime. But we don't have enough of that staff. But we also have the other aspect of on-job training. Sometimes you don't have to go to a short course training in Nairobi, Eldoret, or such like, or America, or such like, but you can do it in your place of duty. And that is why I said the most important thing in this area is making sure that we have good partnerships. And I have to say this, Chairman, and repeat it again, that this will be my number one consideration. That is why when I came in, my number one aspect was to have an accident and emergency unit, which of course I'm in the process, now that I'm coming to this level, together with the rest of other functions that are involved in the county level, we can be able to now equip it, train those who are there so that they can have the new knowledge they might need in support of their patients.
Thank you. You are aware, and we all accept we do not get sufficient funding towards drugs. But the little we are able to get, we have witnessed cases of theft, where the medications have belong to the facility, end up to private pharmaceuticals. That's the case. What do you have in plan I mean, you have been around for 7 years, you know these cases. What do you have in plan, provided that you are given an opportunity to serve as a CC?
Mheshimiwa, it would be very unfortunate for me to sit here and say that, of course, there might be a few cases here and there, to say that openly drugs are stolen from the hospitals. Because when I came here, this was a big demo. Came to see how can we bring drugs within a week. These drugs are over. They have been stolen, taken to. So when I came in, I gave myself 1 month. Told my people, I put out my spies. So many people across. Kindly, if you get something that has been taken from this hospital, I'll give you some reward, so that I'm able to know really these things are taken. Of course, there are people we have arrested here and there. Put somebody with around 1 or 2 vials of some commodities. But really, it is because of the supply. Because you cannot steal what you don't have. So that is why one of the things I said in my submissions is setting up a unit, so that we have money that is ring-fenced. The same way we ring-fenced FIF. This money can be in the hospital, we're running the facility. We can ring-fence some revolving drug fund, some HPTU, the unit, like I said. We ring-fence it. We ring-fence the money by having a legislation. That is where now the Assembly is coming. They give us a legislation so that we, with the regulations that are needed, we have it ring-fenced. And this will help us in continuous supply. Number 2, there is a ruling that was done recently about KEMSA. And now we can be able to get drugs outside KEMSA, because previously, KEMSA used to be the only body where you can get drugs from, whether they are there or not. So we need to now engage further, because I cannot be able to do it alone, but I have this idea. Once it is passed by the Assembly, once it has been brought as a policy to the Assembly, they pass it and becomes a legislation. Then together with my team and a committee that will be set up, we'll sit and look at how best we can good rapport by the way we pay and continuously engaging them. Then these people can even give us these drugs on credit with the faith that we can be able to pay them by making sure that we have them agree we have a fund from where we'll get money, however much the money has been appropriated at whatever time that money is needed to be used. So, Mr. Chair, I have to say, I don't want to say that we don't have cases of theft. After Kwanimba, you'll find that there are areas you bought something and it goes out, it gets its way out. However, it's not as glaring as it's being portrayed. The only challenge we have, Mr. Chair, is supply. We have limited supply. We don't have a regular supply. So those are some of the areas we need to patch up and make sure we have that regular supply of commodities. It's not only drugs. We have these non-pharmaceutical supplies. We have even the technologies that we need, the supplies. So very key, Mr. Chair.
Thank you very much. There are some, I happen to serve as the chairman in the health committee previously. We're even ready to supply drugs to all our pharmacy in all our hospital facilities, provided that we offer technology and a tamper-proof system that can verify the number of medication that has been supplied and the system that can check how the medication has gone right from prescription to discharge. If you go revive in the department, if you happen to have an opportunity, we have all the responses and the remedies of these problems. Our ambulance services, we say let's have a call center, because we might have an ambulance at Amakiri, we might have an ambulance at Manga, and then somebody who is closer, at a vicinity of 5 kilometers, is calling an ambulance from Nyamira referral, when we have one at Manga, but because somebody who is in charge, the phone has been switched off. We have the systems, but we don't have that channel on how best communication can be done, and the people can get services the easiest way and from an accessible service provider within that region. So I think if you happen to reshape the systemic challenges we are seeing, for example, the clocking in of the medical staff.
I mean, we have schedules. We happen to go to one of the facilities here at Tinga, and we find we have 4 maternity cases with one nurse on duty. When on the register, we had 8 people who are supposed to be on duty. So 7 are at home. And now when we merged in as a community, she's busy calling those ones to leave their duties to come and help. When we have 4 cases in the maternity, and we have someone at the triage who had an accident, who is bleeding, and you are only one on duty, when we are supposed to have 8. We have a case in Mangu. The lab is closed at night. Here is a patient who needs to be diagnosed with a problem, but the medics didn't know that I was the chairman, and they are trying to cover somebody who is not on duty, that the lab services are not there, so they are prescribing medication without first diagnosing the problem. So we have this disease across. If we want to have the biometric way of every facility, like from your computer, from the office, you can be able to know you have the schedule of the facility, and you have somebody who's supposed to be on duty. Through logging in using biometric, you are able to assess that a facility somewhere of the 110 facilities we have as a county, so and so we have a problem with reporting and living on duty. Now then, when your team goes around, you can be able to verify.
Yes.
You can press a button from the office, go to the certain facility, and bring us the report what's happening there.
Oh, yes.
So if you embrace the ICT, including medication, including staff reporting to work, and then we polish on the few issues of trainings and other things, I'm sure Nyamira will be great. I have hope in you. You are youth, you are medic. Personally, I'm a paramedic. So when these issues come across, I see a huge gap when we have the solutions at our fingertips.
Mr. Chairman, on
Hope
that
you
line,
embrace that.
Mr. Chairman, on that line, I want to thank you so much for what you've raised. And there is a program that has been piloted. Even now, it's being used in 2 facilities, Tinga and Kerenyo. We call it Elephant. So one time, from the office, my boss decided to see what is happening in Kerenyo. And so they looked and realized there is a staff who has gone on duty. But somebody is calling from Kerenyo and saying that we don't have we have sat here for long and we've not been able to be seen. But when my boss was looking at the system, he had seen somebody signed it. So they decided to pick their gadget and call that staff, "Where are you?" And the person said, "Oh, I'm in Nairobi." Which means this staff gave credentials, their credential to somebody else. So basically what you've raised is very key. There are systemic issues that needs to be sorted, and it needs somebody who can face these facts. It needs somebody who will sit and realign. It needs somebody who is also ready to go and face that problem. And I think I'm that person who's suited for that job, so that I can go and face this head on. Because I know it will not be easy, Mr. Chair, to need a lot of support, including the Committee of Health, so that together we can work and make sure this is worked on and it works. Let me tell you, in better places, in organizations where our people are working, of course they are not enough. Workers are not enough. But if you can have measures of making sure these people are there, you are supposed to be on duty, and be on duty. They should not pay you for work not done. So if this is embraced, I know it will be a tug of war, but I'm ready to face it. What is the total, these are the outcome at the end of the day, that our patients will receive services. That is my problem. If the patients will be happy, if the community is happy with the services that are being offered, well, the people I'm working with, I respect them so much. The healthcare workers, I salute them for the good work they are doing. But there are a few elements whom we need to put in line, panel beat and train them on the best way of working. And I know I have enabled staff through which we can work together through consultations. And like you said, Mr. Chairman, that we can have this dispensed to it. We can have our facilities getting what they want. If we can have the technology, the aspect of technology taken up In Tinga, in Kerenyo, we are having technology of clocking in and clocking out. Once the piloting was done, because it is something that has been budgeted for. Money is there through one of the partners who rolled out that project, so that we have these rolled out to all our facilities.
Thank you. And the
That
biometric
is
is the way to go.
Yes.
Logging in with credentials, you
Yes.
have somebody logging from Nairobi, already in Nairobi, but already seem to be in the facility.
Yes, yes.
And you say of most recent days, we haven't witnessed some strikes. And then I heard you mention you were in the union.
Oh, yes.
So might have you been the one behind it? Don't happen.
Mr. Chairman. You see, Mr. Chairman, in unionism, one thing I've noted is about dialogue and engagement and talking, but not flexing muscles. The moment you flex muscles, they will want to show you that they have power. Article 41 of the Constitution allows them to come out and picket, to engage in that activity. So there was a deliberate move in the with the government, with the ministry, and the unions to come together and start engaging in dialogue. Previously, we had a challenge in engaging in that dialogue, but even while I was seated as a seated medical superintendent, I've been engaging with my union because I knew this is what I wanted. Anytime I had issues, I needed somebody to sit with me and we talk. But it felt like nobody was ready to sit with me and we talk. But the team I was working with. But as I came in, one of the things I embraced so much is dialogue. Whenever I'm hearing some level of discontent, call these people, sit down. We find a way out. Then we move it up to the department, and that is how we've managed to be free of strikes.
Maybe the final part of it, just to break it down, Dr. We talked about systems, we talked about, I think, in the whole of this conversation. What do you think needs to be fixed urgently?
Urgently, in our health department, we need to fix the issue of supplies. We are on media every day as Nyamira because we don't have enough supply. We are on media every day because of people appreciate the services we are giving. People appreciate the doctors. People appreciate so and so. But now when they get to where they are supposed to receive drugs, it becomes a challenge. So the immediate thing we are going to fix is supply. Making sure that at least we have supply. It may not be enough, but that optimum level of supply.
How many doctors do we have in our county?
Generally in our county, we are around 56 doctors. That includes dentists, pharmacists, and medical officer, both medical officer general and consultants.
Maybe a final remark. I want to congratulate you for the way you have the leadership in case we have put you. And maybe caution you that previously we've had the CCs who are also very good, actually skills, very good. You know the chair knows, very good in talking. The only challenge we've been having is translating that from to action. That's the biggest challenge we're having. I beseech you, in case you are approved, you are good in talking, please go and address that challenge. The ground.
So that for ground things will not be different.
And we'll be having a performance appraisal.
Yeah.
Probably if you get an opportunity in the next 2 years, when you come, I want to see the nitty-gritty is fixed.
Oh, yes.
It's there, and this committee has powers equivalent to the High Court. You have an opportunity to go to the Assembly to furnish us on how far and what steps you've made, because healthcare
is so key to every class. So we wish you well. If you have a parting shot, you'll have an opportunity to share with us.
Honorable members in this committee, I want to thank you so much for giving me the chance to sit and give a view on what I think I should do for the people of Nyamira when given a chance as the CEC member. I want to thank you for being objective in raising the questions and in looking at issues and not personalities. I want to thank you so much for the opportunity, and above all, one thing I want to tell you and tell the people of Nyamira is that when given a chance, I'll try my level best and give service to our people. Thank you so much.
Thank you. We appreciate it, and we wish you a pleasant day. We'll get communication with the chief analysis and its findings. And the same way you are communicated to, the same way you get a response from our people. We should do the best.
Thank you so much, Mr.